Good morning, everyone. So I'm going to be presenting today on what's considered one of the landmark trials in OBGYN called the CHIPS trial on less tight versus tight control of hypertension in pregnancy. So let's get into the who, the why, the what. This was a open, multi-center, international randomized controlled trial that was coordinated by the University of British Columbia and published in the New England Journal of Medicine in 2015. Why was the study done? Well, as we pretty much know, hypertension is really common. At the time of the study, it was estimated that hypertension affected up to 10% of pregnancies, and it was basically broken down into chronic hypertension, gestational hypertension, and preeclampsia. And also at the time of this study, the treatment of blood pressure at certain thresholds wasn't well defined. For example, there was a big debate about the use of antihypertensives liberally and early, and if it could prevent maternal and fetal complications of uncontrolled hypertension, versus fear that too tight control, dropping the blood pressure too much, would lead to things like fetal growth restriction. So their research question was, they wanted to compare tight versus less tight control of non-proteinuric, non-severe hypertension in pregnancy and see what the outcomes were. So who was enrolled? Basically, the study ran from March of 2009 to August of 2012, and they had 95 sites in 16 countries. And to be eligible, you had to have non-severe, non-proteinuric pre-existing hypertension, meaning you were hypertensive before 20 weeks, or gestational hypertension, hypertensive after 20 weeks. And interestingly, they used diastolic blood pressures to define hypertension. So if you were between 90 to 105 millimeters of mercury, or 95 to 105 if you were already getting treatment for hypertension. And they took your blood pressure 4 hours apart at 2 consecutive visits. The second one had to be at least 1 week prior to the randomization. And then they only enrolled live singleton fetuses between 14 weeks and 33 weeks and 6 days gestation. The exclusion criteria, they basically wanted to exclude preeclampsia. So if your systolic blood pressure was greater than 160, though, and the study was very worried about this, they basically, if your blood pressure was above 160, but you could be included later on in the study, especially if you had treatment and then you met all of the other criteria. If you had proteinuria greater than 0.3 milligrams per day on a 24-hour urine, a protein creatinine ratio of 0.26, or dipstick of 2+, you couldn't use ACE inhibitors at or after 14 weeks, and you couldn't have pre-existing disease like pre-gestational diabetes, renal disease, no multiple gestations, no anomalies, no plan for termination. And I'm not sure why they also had to specify this, but you could only participate once in this trial. In terms of the randomization, they basically used blocks of 2 or 4 patients, and they used a telephone and pager system because there were so many countries involved. They used a 1-to-1 ratio of the less tight control, which was defined as a diastolic blood pressure of 100 or lower versus the tight control, which was a diastolic of 85 or lower. And the control of the blood pressure was expected to the target level until delivery, with the goal of between group difference of a diastolic of 5 millimeters of mercury. And they did this based on like some sort of pilot trial protocol. The first choice recommendation was labetalol, which was and is first line, but you could use ACEs, ARBs, and renin inhibitors, though atenolol was not permitted. So in terms of measuring the results, they basically tested their blood pressures 3 times per visit. And then they would take the average of the second and third diastolic blood pressures. And then based on this, they would use it for medicine targeting. Sorry, guys. She says hello. Um, they also asked the patients to keep a diary of blood pressures, medications, and interventions, things like ultrasounds, visits, and things like that. The adherence to the protocol was based on these diaries for the first 4 weeks after the randomization, and then they were seen by their providers however many times that they were recommended. That wasn't standardized. And then at the 6 weeks postpartum, they were given a questionnaire to identify the post-discharge complications. The outcomes were actually looked at by a third-party committee that was not aware of the group assignments and not involved in the patient care. The primary outcomes were focused on the neonatal fatal outcomes. They used a composite of pregnancy loss, so miscarriage, ectopic, termination, stillbirth, or neonatal death, or something that they called high-level neonatal care. So greater than normal newborn care for more than 48 hours until 28 days of life, or discharge home, whichever one was later. And then the secondary outcomes were related to the maternal outcomes and complications up to 6 weeks postpartum. So stroke, death, eclampsia, blindness, and organ damage, respiratory failure, hepatic failure, renal failure, those transfusion. They also did look at some other outcomes like fetal growth and newborn complications, and then the incidence of severe hypertension, which they defined as blood pressure of 160/110 in the mom. Now we're gonna take a brief pause to the much smarter and wiser Dr. Z, who's going to discuss sample size analysis before we go into the results and my analysis of the paper.
Good morning, everyone.
Good morning.
All right, so let's talk about sample size. You saw that this was a really big study, multi-center, multinational study. How do they decide how many patients to enroll in this study? This is an important topic when you do research or when you read research results. It's important to know how many samples do you need to enroll in order to find the difference if it exists, or reject the existence of a difference if it doesn't exist. This is do you see my slide change?
Yeah.
Okay. Sometimes I have an issue with Zoom that when I advance the slides, you don't see it. So imagine we have this large population. This is where the truth in universe exists, whether there is a difference between the two population or the difference doesn't exist. Of course, we cannot compare, we cannot use the whole population to arrive at the conclusion. We pick a sample of the whole universe and then compare the disease versus normal, treated versus not treated, and then try to extrapolate and use this sample in order to draw a conclusion whether the difference exists or not. So what if we just, for every study that we have, we just enroll thousands of patients? Why should we worry about how many patients to enroll? Obviously, the issue is resources, costs, time. So you really don't want to enroll more patients than you need. And of course, you also don't want to enroll too few patients, because you might not be able to detect the difference if it exists between the two groups. So in research, we have two types of errors, as you know. Going back to the basics, you have type 1 error and type 2 error. Type 1 error is when you falsely arrive at the conclusion that the difference exists between the two groups, but that difference actually doesn't exist. And this is a good example to keep in mind. Type 1 error means the difference doesn't exist or the finding doesn't really exist, but your research falsely arrived at that conclusion. Type 2 error is when the difference does exist or an entity does exist, but you miss it. The type 2 error is more related to sample size. If your sample size is small, you're more likely to commit type 2 error because you don't have enough number of patients, enough number of subjects to find that difference. So sample size is more or less they're related to type 2 error. In average, it's completely arbitrary that type 1 error, we set a 5% chance of type 1 error that we can tolerate in our research. But we want to be 95% sure that if we find a difference, it does exist, we accept 5% chance that that finding could be due to chance. So type 1 error usually sets at 5%. For type 2 error, we usually accept 20% chance of error in research. These are completely arbitrary, and we'll discuss these more in future slides. So when we talk about sample size, there's a concept that's called power of the study. That's probability of correctly rejecting the null hypothesis. This is double negative, forget about this one. But basically it means how accurate or how powerful your study is to identify the difference between the two groups if it exists. So that's power of this study. When we say what's the power of the study, the power refers to how sensitive the study is to identify the difference if it exists. And the formula for power is 1 minus type 2 error. And remember, we said type 2 error, we usually set at 20%. So power of a study should be at least 80% or 0.8. So sample size is the minimum sample size or minimum number of subjects that we need to achieve the objectives of the study. And that also sometimes is referred to how powerful we want the statistical analysis to be. Generally, we want to see that the trials do their sample size analysis before they start the study. But if they miss it, if they don't report it, we can also calculate it once the study is done. And when you read a published paper that doesn't have a statistical, in their statistical analysis section, they don't have sample size calculations. When the results are out, we can calculate the sample size and say, they didn't find the difference between the two studies, between the two groups, because the study didn't have enough power or the sample size was not enough. So it can be done prospectively before the study, and that's what is advised. Or if they don't do it, we can do it ourselves. So what are the elements of sample size calculation? This is actually really easy. This is one of the easiest elements of research. When you design your study, there are just a few items that you have to decide, and then you can use any statistical software or online resource to tell you how many subjects you need. First of all, you need to decide what type of analysis you're doing. Are you comparing two proportions? Are you comparing two means? Are you just arriving at one proportion? We'll talk about this in the next slides, because it matters how you calculate the sample size if you're comparing two means or two proportions. Alpha level, it's set at 5% or 0.05. Sometimes you're looking for measuring the efficacy of a drug that is extremely toxic, or you are looking at a disease that is extremely lethal and you want to reduce that chance of type 1 error to 1% instead of 5%. And if in that case, you set your alpha at 0.01 or 1% instead of 5%. But in general, everything is preset by default as 5%. And if you want to change it, you have to have a good justification for it. Beta or power or chance of type 2 error is usually at 20% or 0.2. Again, you can, if you want the study to be more powerful, you can set it at 10%. So when you say beta at 10%, that means the power of a study will be 90%. And if you put the chance of type 2 error at 20%, then your power of study is 80%. Effect size is the minimum difference between the two groups that you're going to consider significant. So this has to be something that makes sense clinically. If you're looking for a change in, looking to see if a drug, antihypertensive drug reduces the blood pressure, if you set your effect size at, let's say, 10 millimeter mercury, that might not be clinically significant to clinicians or to the patients. But maybe a 20, maybe a 30 millimeter mercury is more significant clinically. So before you do the study, you have to decide what changes in the outcome are you going to consider significant. And that is your effect size or your delta. We will talk about a few samples in the next few slides. And then you will decide the details of the study. When you are giving a medication to your patients to, let's say, decrease the admission rate or decrease the ICU rate, your assumption is that that drug is going to reduce the admission rate. But you will never know because that drug might actually increase the admission rate. So you always have to think that the direction of the results might not go the way you want it, and it could go the other way. So it's always better to think two ways, that we don't know, but even though we are expecting the drug to have this effect, but it could go the opposite way. That's the definition of two tails versus one tail. By definition, by default, usually we set the study at two tails. And if you want to change it to one tails, you have to have a good justification for it. And lastly, what you need, if you are comparing two means, then you need to have the standard deviation input. So if you have, before you do the study, you can decide, that your outcomes, are you dealing with means or proportions? For example, if you're doing, you're looking at admission rates, percentage of people get admitted, that's two proportions. And if you're looking at, let's say, pain score or something else that you're looking at means, that two means, so that is part of the determination. Your alpha usually set at 5%. You put your beta at 20% or power at 80%, the same thing. You decide what would be the minimum difference between the two groups that you're going to consider significant. You set your tails of the analysis two tails, assuming that the study can go in either direction. And if you are dealing with means, you decide your standard deviation. These are the types of analysis. As I said, you can have two means, two proportions, overall proportions. You can also do sample size calculations if you're looking at correlation between two elements, two variables, or survival rates. The top two means and proportions are what we generally use for our sample size calculations. Where do you get the effect size? Usually you can look at the previous studies. You can say the previous studies looked at termination of seizure rate at 20% difference, and that could be your effect size because previous studies have reported that. That's a decent way of determining your effect size. If there are no previous studies or you want to get your own, you can do a pilot study, meaning that, enroll 20, 30 patients first, see what the difference is between the two groups, and then use that as your effect size. Or you can use clinical judgment. In clinically, I will consider this much difference in admission rate, in ICU, length of a stay, in hospital length of a stay, or blood pressure measurement, this much difference I will consider clinically significant. This sounds arbitrary. It is arbitrary, but it has to make sense. It has to be something that your peers and other researchers and investigators agree with you. So we want to know if you give magnesium to children with asthma exacerbation, whether that reduces the asthma admissions, right? The admission rate is a proportion. So the type of analysis that you're using is two proportions. Admission rates for pediatric asthma exacerbation is generally 30%. That's the number that you can get from the literature. So how much do you want to drop that admission rate for magnesium? Because magnesium has side effects. It's not an easy drug. You need to have IV. You need to give it slow. So you want to have a really effective drop in admission rate in order to consider magnesium a treatment option. So what is the minimum clinical effect size that you will consider meaningful? Let's say 50% drop. So you want to, if the baseline is at 30%, you want to drop it by 50%. If magnesium drops the admission rate from 30 to 30 to 15%, then we'll consider that clinically significant. That is your effect size. That's how you determine the effect size. We set the alpha at 5%. We set the beta at 20%, which again, it means power of 80%. We want to have a two-tailed analysis because magnesium, even though we think it's going to reduce the admission, it could also increase the admission rate. You plug this into a online calculator or a software, and it gives you your sample size. Generally, whatever you have, they recommend that you add 10% or 20% to your sample size and leave room for withdrawal. Sometimes people withdraw from the study. Sometimes people are lost to follow-up. Sometimes the data is lost. So it's always better that whatever number you get, let's say here is 50, that means you have 50 patients per group. So you need a total of 100 patients. You add 20%, you enroll 120 patients, and leave that 20 extra is for people who would withdraw or the lost to follow-up or other. So again, decide type of your analysis, decide your effect size, plug in alpha and beta. Don't even think about two tails or one tails. Put the two tails in there, and then you will get the number of samples that you need in each group. All right, easy peasy. The other option is when you're comparing two means. The mean pain, let's say, how effective is Toradol for kidney stone? The mean pain in 1 hour in control group is 10, and you want to drop that mean pain level to 5. That's 50% reduction in pain. If basically what you're saying is that I will only consider Toradol effective if it drops the level of pain from 10 to 5 in 1 hour. That 5 is your effect size. A standard deviation set at 2. You can get this from previous literature. Again, alpha and beta the same. Two tails of study, no question. Plug this in, and you get a sample size analysis per group. So if it's 50 again, you have 50 per group, total of 100. Add 10 or 20%, and you have your total sample size. This will reassure you that if at the end of the study you don't find a difference between the two groups, your study was powerful enough, and your sample size was large enough that if the difference was there, you would have picked it up, you would have identified it. So the chance of type 2 error is minimal. Couple of things to know when you play with your sample size. If your effect size is small, if you're going after very, very small differences, you're going to need huge sample size. For example, let's say the mortality from trauma, from multi-trauma is about 2%. If you're doing an intervention that you expect it to drop the mortality from 2% to 1%, that 1% is a very, very small effect size. And that means you're going to need thousands of patients. So the smaller the effect size, the larger the sample size. The power, we talked about this. If you are using, if you're doing a study that involves a very toxic treatment, or the disease is lethal and you want to have a more powerful study, the power goes up, you're going to need more sample size. And the same thing with alpha. If you are willing to take less chance of type 1 error and you want your study to be more strict, then your sample size is going to be higher. Let's see if I can do this. Do you see the my screen?
Yeah, we see a link.
Oh, you don't see the screen. Okay, give me 1 second. Let me see if I can change this. So this is one example of an online calculator. So you put in here, let's say, example of magnesium sulfate for reducing asthma admissions in children. So the first group, the value is 15%. The second group, it's 30%. It doesn't matter which one you put there because what matters is the difference between the two. And then you see by default, two-sided, alpha is 0.5, beta is at 20%, or power is at 80%, and you click on calculate, it gives you need 121 patients for each group. So you need 242 minimum number of patients to measure this difference. If you reduce your sample size, if you want to go for a smaller difference between the two groups, make this 25%, you will see that then look out for this number, it almost doubled. So when the effect size becomes smaller, the sample size increases. Now, I want to reduce the chance of type 1 error. I want a stricter study. I don't want to leave anything to chance. So I'm going to reduce my chance of type 1 error from 5% to 1%. Watch the sample size. Boom, right? So you need more sample size if you want to have a lower chance of type 1 error. And here, I want my study to have more power, which means I'm taking less chance of type 2 error. So I went from 80% to 90%. Again, that goes much higher. So these are the things that you need to consider when you're doing your sample size analysis. It's really easy, not very complicated, and this is something that you should look for in every study that you read, especially if they determine that there is no difference between two treatment or between two interventions. What you want to do is to make sure that they had enough sample size or enrolled enough subjects that they didn't miss that difference because of the small sample size or because the study was underpowered. Any questions? All right, I take that as that was very easy. All right, Dr. Ahmed, you want to?
So, Shaya, just one thing about composite outcomes. So one way to get around a sample size inappropriately is to increase the number of composite outcomes and do the sample size calculation instead of on a single outcome, multiple outcomes, which you need a much smaller sample size. And this is a common error, especially in drug studies.
Well, correct. It's not an error. It's a what do you call it? Informed decision. They make this when you use composite outcome, you significantly increase your chance of finding statistical significance. So they know what they're doing. But whenever you read a study, and at the end, if you have time, we're going to look at this study in particular. You have to look at the outcomes, as Dr. Sinner said, there is a reason why they do this to reach statistical significance. Whenever they have composite outcome, you have to look at the outcomes separately, no matter what the study says or whatever they do.
Well, thank you for explaining that much better than I would have. So back to our study, I just want to comment on the sample size. So they used 95 sites, 16 countries. They found 1,030 eligible patients, 519 for the less tight group, with again a diastolic blood pressure less than 100, and 511 for the tight group, with a diastolic blood pressure target of less than 85. And the study actually included a very nice graph explaining the sample size. So we'll just briefly go over that. So here, again, they started with 1,030 eligible patients split between the two groups. Ultimately, one site was excluded, so they had 497 in the less tight and 490 in the tight group. 6 were lost to follow-up or withdrew. 24 patients discontinued their blood pressure treatment prior to delivery, but their data was included as part of the intention to treat analysis. 10 patients, 5 in each group, had incomplete data or no postpartum survey, and 21 were found to be ineligible after the data analysis for whatever reason. They found that adherence to the protocol was slightly worse in the less tight group, 76.6% compared to the tight group. So to the study's credit, the baseline characteristics between the groups were actually very similar in terms of BMI, null parity, gestational age at randomization, gestational diabetes rate, and smoking. About 25% in each group had gestational diabetes, and 75% had chronic hypertension. 16% of the less tight group and 12% of the tight group had severe range blood pressures at some point prior to the enrollment, but they found that this wasn't statistically significant. And 57% in each group were on antihypertensives prior to the enrollment. Unsurprisingly, the blood pressures were higher in the less tight group by an average of 5.8 millimeters of mercury systolic blood pressure and 4.6 diastolic blood pressure. The antihypertensive medications were taken by fewer patients in the less tight group after randomization, about 73.4% versus 92.6%, and this continued after delivery, 65.5% versus 78.3%. And as it was expected, labetalol was the most commonly used antihypertensive, and there were 4 protocol violations for the use of atenolol prior to delivery. So as per usual, when I read any research paper, I found the stats to be confusing, especially their explanation or lack thereof for why they chose the seemingly much more severe maternal outcomes to be the secondary outcomes. And then on top of that, for them to also put a much more stringent p-value of less than 0.01 to make those outcomes significant statistically. So as Dr. Z said, effect size measures the size difference or relationship, and they decided that effect size ahead of time, and they determined what they wanted for the alpha and the power. So with a sample size of about 500 per group, the power of the study was estimated at 80%, which is the threshold for detecting a real effect if one exists. And they did use a two-tailed alpha level of 0.05, and the 2 interim analyses were calculated with a chi-square test. The primary outcome, they used a mixed effects logistic regression model, whatever that means, with a lot of adjustments for stratification factors, and then their alpha level was set at the 0.046 level. And then for the secondary outcomes, they again used a two-tailed p-value, but this time with less than 0.01. And their justification was to accommodate the many comparisons made. Like Dr. Lee said, during a sample analysis, adding that extra 10 to 20% is standard procedure to account for expected participant withdrawals, dropouts, loss to follow-up. This adjustment ensures that the final number of participants who complete the study is large enough to maintain the study's statistical power. this study did not include such an analysis, and it seems like they likely um, either didn't do this or didn't disclose if they did. The difference in the p-value between the primary and secondary outcome, the fact that they made neonatal outcomes primary and not the maternal outcomes, seems to imply that they did do a sample size estimation for the maternal outcomes first, realized they needed too many patients beyond what they had already enrolled. So they moved the maternal outcomes to secondary outcomes and made the conclusions exploratory. So just to briefly comment on the primary outcomes, they did use a composite of pregnancy loss, meaning miscarriage, ectopic, termination, stillbirth, or neonatal death, or high-level neonatal care, greater than normal newborn care, or more than 48 hours until 28 days of life or discharge. And this is a separate issue, as Dr. Sinner and Dr. Z commented about using composite outcomes. So we're just going to look at the two primary outcomes separately. There was no statistical significance in the adjusted odds ratio for pregnancy loss between the less tight and tight group. And then there was no statistical significance in the adjusted odds for high level of neonatal care between the less tight and tight group. And then they also include many more analysis on these tables as well. Now onto the secondary outcomes, which focuses on the maternal complications. Again, they used a p-value of less than 0.01. Like the primary outcomes, these secondary outcomes here are not clinically significant. You can see that their 95% confidence intervals cross. They use this to conclude that the less tight control did not significantly increase the risk of serious maternal complications. There weren't any maternal deaths, and the severe events that they were looking for were actually pretty rare, which is something to consider. But if you look at the adjusted odds ratios, it should give you pause. For example, there were higher frequencies of severe hypertension in the less tight control group, 40.6% versus 27.5, 1.8-fold difference. There was a twofold higher rate of abnormal labs, thrombocytopenia, liver enzyme elevations, LDH, markers of severe preeclampsia, and a fourfold difference in HELP syndrome. And yet with a p-value of less than 0.01, the difference was not considered to be statistically significant. There's a discrepancy here that should make you hesitant to say that the risk of these maternal complications is the same in these two groups. There's a very high chance here that there's a type 2 error because the sample size is too small. So just to reiterate what Dr. Z had already commented on, and a topic that I always need repetition on, so I thought I would give it to you guys. Let's just comment on type 1, type 2 error and power using this flowchart. So if the null hypothesis is true, there is no difference in the population, then you want to fail to reject that, meaning you made the correct decision. Based on the research, you can interpret the p-value wrong or do the calculations wrong and then reject the null hypothesis. That would be a type 1 error. You incorrectly rejected a true null hypothesis. If the null hypothesis is actually false, meaning that there is a difference in the population, but you just couldn't find it, then that's a power issue. And you are more likely to make a type 2 error. So a false negative in hypothesis testing, you missed a real effect or a relationship that actually exists, which is what we're implying here with the secondary outcomes of this study. So in the sample size estimation, It is used to determine the number of participants needed for a study to produce valid, reliable results. It does include many factors, many statistical factors, like Dr. Z included, like the confidence interval, margin of error, power, but also practical factors, factors that can be manipulated in studies to favor and be used to justify a smaller sample size. So generally, the larger, more diverse the population, the larger the sample size needs to be. A smaller sample size is easier to justify when you use probability sampling, like random sampling in the study. The more variables are measured, the bigger the sample size needs to be. And then for exploratory research, such as the secondary outcomes in this study, it tends to call for smaller sample sizes compared to causal research. So just other considerations when you take into consider sample size estimation. So this is what the authors concluded based on this study. On the infant side, they said there was no significant difference in risk of adverse prenatal outcomes. And on the maternal side, they said less tight control did not significantly increase the risk of overall serious maternal complications, despite less tight control having more significant rates of severe hypertension and lab markers of severe preeclampsia. This paper actually allowed for the dominant paradigm for many years for permissive hypertension. It allowed treatment prior to significant values consistent with severe blood pressure to not be performed, and gestational hypertension to typically not be treated until the severe range pressures. Now those pressures are considered to be preeclampsia. Another consideration is this paper lumped together gestational hypertension and chronic hypertension, despite the majority of their participants, 75%, having chronic hypertension. And it begs the question, is clinical significance the same thing as statistical significance, especially in regard to the secondary outcome analysis of maternal outcomes and the possibility of type 2 error due to not having a big enough sample size? If you guys are interested and want to learn more, there are actually much more updated studies that ask these questions and critique this paper. The CHAP trial, which was published in 2022, it now actually favors much more tight control. These are my references. I'm done torturing you guys, I promise.
So just to add one or reiterate what Dr. Ahmed said, when you read a paper, only focus on the conclusions from the outcome that sample size analysis that was used for sample size analysis. That's your primary outcome. A lot of studies, even this study that was published in New England Journal of Medicine, they drew a lot of conclusions from the secondary outcomes, even though they knew that they didn't have enough sample size. Even though those the secondary outcomes were what we care about more, the severe maternal outcomes, but they didn't do sample size analysis for those, and the chance of type 2 error was very high, but they still drew conclusions from it. And you will see in a lot of papers, they draw conclusions from secondary outcomes that they didn't do the sample size analysis for. They draw conclusions from subgroup analysis that are almost always underpowered and the sample sizes are small. When you read a paper, only focus on the conclusions that are drawn based on the outcome that they did the sample size analysis.